Dr. Mau Mau. We have another one from Dr. Rob Tenbrick, and we'll be introducing it in due time, and Dr. Sarah Cookie, before we have a plenary session. So in case you have any questions in the course of the presentation, jot them down. We shall take all questions at the end of the 3 presentations. Skagis, you're ready with the presentations? Okay. So let me give the people registering about 3 minutes, then we can pray and start. Good morning once again. A very important presentation from the Pride-In team on how we'll carry ourselves out during the day and the amenities available. So I'll invite Grace to make the presentation.
Good morning. My name's Grace. I'm in charge of security in the side of the conference. I'm here on behalf of Pride-In Management to welcome you at Pride-In Paradise. In our hotel, we do have maximum security. All the corners of hotel are covered by a trained guard and 2 policemen on patrol always. Wherever you walk in our hotel, get guidance from a guard or a policeman on patrol. The time you walk to the beaches, make sure you visit KWS office so that they give you the guideline about our beaches. Do not walk through the beaches without their guidance. The rooms are always guided by a security guard. So during the lunchtime, just feel free to leave your things here. We shall take care for them. Do not walk with them in the dining areas because we have so many people in the compound. They are safe when they are left here in the dorm tent. We do have medical services in our hotel. In case you doctors you need assistance from our doctor, she's always available for you. The printing services are done in our convention center, the main convention center. There is a business center where you can do the printing. The nearest washrooms when you are here in the dorm tent is just next to the big convention center. There are washrooms there where you can use when you are in dorm tent. The tea time is served 10 o'clock to 11 always, and 4 o'clock to 5. I think yesterday most who are here, they know where the tea area is. It's just around here, the opposite, the dorm tent area. That is your tea place. The lunchtime, you will be directed during the lunchtime where to go for lunch. We do have a free Wi-Fi. The password is Paradise 2023. Small letters, Paradise 2023. You can just make use of it. It's all available in every corner of hotel. In case you need assistance, just see the guard who is always at the door so that he can help you with anything you want. In case of emergency, you just use this exit door. You walk outside. There is a compound there by the name Elpan. Is where we do go in case of emergency. We are just there to direct you. In case there is an emergency, we are there. Have a good day and enjoy yourself in Pride in Paradise. Thank you.
Good morning, colleagues. Welcome to the Pride Inn. I am Dr. Brenda Obondo, the Chief Executive Officer of Kenya Medical Association. And today I have the pleasure of welcoming you here to the coast for our 50th annual scientific conference at a time when we are focusing on the discussion on planetary health and advancing the climate change agenda in the healthcare space. KMA also welcomes you to celebrate the East Africa Medical Journal at 100 years. We look forward to a fruitful and colorful scientific conference and East Africa Medical Journal celebration. Karibuni sana. So I'll welcome Dr. Yosa, who is our co-chair for the session today, to take us through.
And you're all most welcome, and you're privileged to be in one of the best institutions catering for this. That's Pride Inn. I'm sure you'll be very comfortable. And our first speaker is a very rich CV. They are together with Professor Rogo. Professor Rogo was one of our great former chairman of our association. And the first presentation is going to be given on his behalf by Dr. Mau Mau. You know, Mau Mau in Kenya means a lot, but you'll explain the relationship. He is at the moment, he'll introduce exactly the areas where he has been performing, but he is an obstetrician and gynecologist, and he's done a lot of research work in cancer research, done a lot of cancer research. He's worked in the past with Pfizer and Merck, and is passionate about cancer research, early diagnosis. He is president of Asia Research Cancer Group. And Dr. Mau Mau, you're most welcome to give your presentation. You can add 1 or 2 words on exactly what you've done. Maybe we welcome the first speaker with a clap. Karibu.
Good morning, everyone. I want to thank the organizer and the chair for us to be here to present our research work. And I represent a patient advocacy group, Inspire to Live, headquartered in Amsterdam. And so Rob will be the next speaker. We have 2 speakers today. And Robert and I cover the two ends of cancer care. So my focus is cancer early detection. Rob takes care of those later stage patients, especially for the pain management. So in the past 10 years, my work was focusing on cancer early detection. So here is the title of my talk. So cancer is a global problem. It's not just for rich people or for poor people, and also it's everywhere, as long as you are alive. So the question is how to control it. There are many ways to do it. This is a number shows the difference between early and the late stage patients. If you are early stage patient, the likelihood to be survived is very high. But if you are later stage, no matter what you have, no matter how rich you are, and it's very likely you're going to die. So the question is, how can we identify early stage patients, especially when they don't have symptoms? So there are many ways to do it now, at least in the United States. There are 5 cancers have been screened routinely: breast cancer, prostate cancer, colon cancer, cervical cancer, and lung cancer. But then if you look at this, there are still roughly 70% of the cancers. Today, there is no screening method. So the task for us is to develop new screening strategies or methods for the other cancer types, especially can we have one test for all. So that's my dream. The dream is not just to screen all the cancers using one method, but also to be affordable and accessible. It's not something like a car service. When you're rich, you can have a car service. I want to build a subway for everyone from point A to point B. I want to build a subway like the Shanghai subway. It sells 10 million tickets a day. So that's my dream, and that's my scale, the scale I want to achieve. So this is the biology. So there are a lot of biomarkers we can look at to identify cancer. So there are 2 categories. One is DNA, the other is protein. So basically, cancer cells release their protein and the DNA into bloodstream. If we have a sensitive test, if we can detect different biomarkers of different cancer types, we may be able to use one tube of blood to cover all the cancer types. So now we have 2 versions. One is to detect cancer DNA, so we call circulating tumor DNA. And we use a very expensive method. We use a very expensive instrument called Illumina DNA sequencer. The sequencer itself costs roughly $1 million US. And the test now is around $1,000 US. But it's a good test. It is expensive. On the other side, we're also looking at the proteins. There are cancer proteins have been used in the past to detect cancer, to diagnose cancer, and to monitor cancer. So you are familiar with those tumor markers, such as AFP for liver cancer, and you can also use CEA to screen the GI cancers. So then the idea is, can we combine these proteins together to screen multiple cancer types instead of one marker for one particular cancer type? So, and also those instruments for protein markers are very popular. They have been used for decades. So they are not like DNA sequencers. You can only find them in very rich countries. But the protein instruments can be found everywhere. This is just using an example to show the Roche corpus can cover quite a lot of different protein markers. And this data, just to show you, if we use 7 markers, and we can see the differences of those markers in 8 common cancer types. They are all statistically significant. But the problem is, if your dream is to combine different markers to screen different cancer types, then you can see we have a problem, which is we certainly can increase sensitivity by combining different markers, but in the meanwhile, we will decrease the specificity because each marker can introduce its own false positives. You add all the false positives together in this case, then the specificity is around 70% if we use 7 markers by this conventional way. And 70% specificity means 30% false positives. If you screen 100 individuals, there will be 30 false positives. That's just too many. So the question is how to reduce the false positives. In the meanwhile, to retain the sensitivity. So here comes the AI, the artificial intelligence. So we have a special algorithm to use AI to help us to maintain the sensitivity, but in the same time to reduce false positives. We also use clinical characteristics like gender or age help us to get a better sensitivity in this case. So here is the study we have done in the past. It's roughly 10,000 individuals here, and we divided them into 3 different cohorts, 1 training cohort and 2 validation cohorts. And we use validation cohorts to confirm they have good clinical performance. And in this study, we cover 8 common cancer types. As I said, we have 3 cohorts. The first one is our own training, or we use it as a training cohort. The second one is from a big hospital, Sun Yat-sen Memorial Hospital in China. And the third one actually is from United States, from Johns Hopkins University. And in this case, you see there are quite a different variables. So in terms of sample type, we have plasma. In the meanwhile, we also have serum. And for the Johns Hopkins study, there are only 6 markers instead of 7 markers. And the Johns Hopkins study was on a different platform. So you see different variables here. But again, I want to show you, although it's different variables, we still have good clinical performance in the validation studies. So this just try to put them together to look at the training cohort and the 2 validation cohort performance. You can see by this AUC curve, area under curve, this parameter. So you can see the 3 cohorts give us similar performance in 3 different cohorts. And here is a comparison between the conventional clinical method, basically to analyze 1 marker at a time. And our method is called OncoSeq, using an AI algorithm to analyze the marker together. And then you can see the big difference is the specificity. So we can, in this case, we can have 93% specificity, but still we can get 52% sensitivity in this case. So the specificity now is much better than the clinical method and the conventional method. So this here is the performance in 8 different cancer types. They are all common cancer types in this case. Sorry, there are 9 different cancer types. And you can see some cancer types we have higher specificity, some we have lower specificity. And usually for the lower specificity, we may not have good markers to cover the tumor type, but also for those cancer types, when they are not aggressive, usually you have lower sensitivity because they don't release a whole lot of cancer protein into the bloodstream. So that's why we have pancreatic cancer as a very high sensitivity in this case. And this is also very similar to the ctDNA study. And also, if you break down into different stage, you can see in the early stage, the stage 1, we can still have a quite good sensitivity. In this case, is 44% in the very early stage 1 patients. So the other thing we need to do when we detect using blood to detect the individual has cancer, then we need to decide where the cancer is, right? Then you can use imaging approach to confirm the cancer. So we also have another artificial intelligence algorithm to decide where the cancer is, basically the tissue of origin. So if we look at the top 2 tissue of origin prediction, the accuracy is 67%. So we have a pretty good accuracy to decide where the cancer is. So here's the overflow for the implantation. So we can start with a tube of blood, which could happen in a village, in a remote village. So then we use the regular shipment, basically in this case, could be a postal service, because we are using a special blood collection tube, and the proteins are stable in the tube for up to 7 days at the room temperature. And then we ship those samples to a central lab using the conventional clinical instrument to analyze the 7 proteins. So then we use the artificial intelligence algorithm to understand whether the individual has cancer or not. And if it's positive, so then we decide where the cancer is. So this is more details how to do this, basically. And so we have mapped every steps for the implementation. So as I just showed you the advantages for this particular test, it's built on a conventional clinical instrument. So we don't need those very fancy, very expensive DNA sequencers. And it only needs a tube of blood, and the blood can be shipped at the room temperature. And analysis could be fully automated, and the AI algorithm is also fully automated in this case. Again, so we want to address the accessibility and affordability in this case. So the cost for the reagents of this test is roughly $20 in this case, instead of, as I said, the fancy DNA version is around $1,000 US. So we are here, we are looking forward to do some type of implementation work in your country, and we are also look forward to do some prospective studies to further to validate the test, and also to understand how to implement this type of test in your country. And those markers and instruments have been approved worldwide. And the algorithm now is approved in European Union, so we have the CE mark for the algorithm. Thank you very much.
Thank you very much, and give him another applause. He's the first speaker. I think I'll call Dr. Elizabeth now to introduce the next speaker. Thank you.
Good morning once again. For those who are not here, my name is Dr. Elizabeth Gitau. I'll be introducing our next speaker, who is Dr. Rob Tenbrick, who will be speaking on pain using lidocaine as an anti-inflammatory approach. So Dr. Rob Tenbrick is an MD and a PhD holder who's also an anesthesiologist and a pain specialist. He was trained by Professor W. Edman to become an anesthesiologist from 1996 at the Academic Hospital in Rotterdam. He's worked on high-end projects including xenon during anesthesia, modern ventilatory techniques, ischemia reperfusion and organ protection, and liver transplant. He achieved his PhD in 1995 with a thesis, an animal model of the diaphragmatic hernia. And in 2004, he was a co-promoter of John Hofland, MD, abdominal hemodynamic reperfusion phenomena after hypoxemic chemotherapy perfusion. He's involved in high-end cancer research for anesthesia and also is a pain specialist since his recognition in 2009. Indeed, quite an illustrious career. Welcome, Dr. Rob Tenbrick. We are happy to have you here. Welcome.
Yeah, thank you very much. I'm very honored to be here due to the cooperation between Professor Camarogo and Inspire to Live. And I hope that I can show you some new outlines of pain treatment. In fact, you should forget everything you had learned before, because there's a review of the mechanisms according to that are involved in the pain mechanisms. Pain is just since March 2019 a disease. So that means you need specialists to treat this disease, and it means also that you have to revision the idea that pain is not a symptom accompanying other diseases. No, it's a disease itself. And this new idea makes it much more difficult to put it in the old way. So you need specialists to treat your pain. In Africa we have limited resources, so we should consider it in another way, spending not too much money on all those. The problem from pain is that it's a symptom, it's a disease that affects all the social surroundings. The longer it takes the pain, the longer you are affected and the less you are involved in the social network, because you're not able to work. You're not the person who was before the pain having parties, having normal conversations with other people, because you're in your own diseased environment, and that changes a lot of things. One of the things we learned is that pain has to do with inflammation, and inflammation is it's a special branch of our immune system. It's a reflection of the function of our immune system. And that is how we should treat pain. We should modify the effects of the immune system resulting in pain. Is this a correct vision? It's quite recently we know there are much of involvement of the immune system. You can have the publication, it's available online, so you don't have to read it now. But this year they published a very nice thing that there is neuroinflammation in the brain due to pain impulses. And That's something they found also. You can also find neuroimmune types in this immune system. And the first publication they had, that was patient with normal back pain. They followed with the MRI scan, and they found these neuroinflammation parts in the thalamic region. Years ago, Professor Severo, former president of the World Pain Federation, talked about what is causing the pain. He thought there must be something different than the receptors in the end of the where the pain is. Where you have back pain, the receptors are in your back, but the ow is coming from your mouth. So there must be some things between and more things involved. And this is about the scheme. It's just about the scheme. And in the middle you see, in the middle you see the enormous impact of neuroinflammation on many systems. Going down you see the effects in the end. And in the upper column you see the causes of these neuroinflammation. And there are many. And also surprising reactions you didn't thought about. And that's about neuroinflammation. It's involved with many more diseases than we expected now. Where is it going? Yes. Till now, opioids are one of the mainstay for chronic and also cancer pain. Are we on the right track with giving opioids to our patients? I think we are not. And when you see these recent articles that are found, then we see that morphine, that's the most studied drug in pain medicine, morphine has some detrimental effects on your immune system. And especially the second citation, the study in mice were given morphine, and they saw that the metastasis of the melanomas were about twice as fast as in mice without morphine. So we have to rethink, is morphine the right drug to give to all those patients? And this is about where it is the influence of the immune system with the drug lidocaine. There's a connection, many receptors, many transmitters are involved, and there's an interaction. That's why this slide is tonight. It was one of the few I could find, with the interaction between the immune system, the immune cells, and the receptors in the end. So we're changing about a mechanism-based approach, and this mechanism is changing because we know more about the underlying mechanism. It's called neuroinflammation. So we should treat neuroinflammation instead of pain. What's a number, what a name, we can't do anything with it. And we use new drugs. No, lidocaine is not new, 80 years old, but it's a new drug in this area. And lidocaine is cheap, so we don't need to go to newer, much more cheap, much more expensive medications, newly developed. No, we can keep it, we can stick to the old ones, and they're very good. And here you see what is the working of mechanism, without going into detail, is about. You see the blue lines, that's ATP. ATP is one of the most important messenger signals there is in our system. And ATP works also in blue on the P2X7 receptor, forget it. But when you block the P2X7 receptor, ATP has another function. The P2X receptor is a very strange guy, and he behaves quite different with other receptors. And giving lidocaine, it blocks the effects, and in fact what you do with the end effect is you modulate your immune system so the effects are less tremendous. And what you in fact do is change the innate immunity effect into adaptive immune effect. That's, well, roughly say the effect. In green you see the effect, the detrimental effects of the opioids. By the TLR4/7 receptor, you see that it's effective in producing neuroinflammation. So that's what we do with the opioids. So, lidocaine, I mentioned it. 80 years old, and nothing new about. I tried it in a small series of oncologic patients, and it's, well, you should see the effect, and it's amazing. These patients are perfectly clear in the mind, also in a very late stage of their disease. They don't have any pain. I let it accompanied by some low-dosed other drugs, I will mention later. And I didn't see any side effects. Well, that's too good to be true, but I didn't see them. And the dosage is about 1 milligram per kilo per hour subcutaneously. So what we should do and adapt for Africa is find. He was walking in the garden, and a few days after that he was repairing cars as being his greatest post-pension habit. And he also arranged his trip for treatment to Germany. So he had to write and speak in German. And that's a high cognitive, because Dutch and German are not the same languages. That's a high cognitive effort you need in this patient. And when you remember what I described, he was able to speak very clearly when I met him just a few days before. I think this is a very impressive result with lidocaine. So, for practice, we have to adapt a new basic mechanism as a new approach for pain treatment. I use very low dose of gabapentin, amitriptyline, and toricoxib to accompany the lidocaine effect. It increases the effect of the other drugs. And I can reduce the opioids almost to zero, and the only preferred opiate not affecting the immune system very much is methadone, also in a quite low dose. 5 to 10 milligrams a day should be enough. So, lidocaine is also proven, I saw it in Holland, in sickle cell anemia. Visceral pain is very good, react to normal visceral pain, not by cancer. And I'm very anxious to see it in what it does in the onset of malaria crisis. It's also cytokine storm, and that can be modulated by lidocaine. But we don't have malaria in Europe, so it's only a hypothesis. But I think it's very interesting to have results on that. So, we should teach you how to use it. It's very easily, but we should also provide a good infrastructure in using this old new drug. Thank you.
Thank you very much to our two speakers. I'll be asking you, Dr. Rob and Dr. Mau Mau, to have a seat here at the front. My rapporteurs, I don't know, Dr. Serena? And you? Okay. So we're going to take questions. We'll start from this side. Any questions from this side? Okay, Dr. Luoch. Okay. So we have 3 questions this side, then we come this side to Dr. Jakite. So you can have a seat.
You are asking the questions, correct?
So please keep your questions very brief. Give Dr. Luoch at the back there so that he can ask. All right, Dr. Panchal, you can start.
Thank you very much for giving the opportunity to start the questioning session. The first presentation was very good, no comment. We would be happy to have it in this country as soon as possible. We will be. For the second presentation, there are 2 questions. One, any side effects of lidocaine going continuously on the heart conduction? And second question is any comparative idea about the acupuncture, because acupuncture has been used for years for controlling the pain. So acupuncture and the cardiac side effects of lidocaine, I would like to know these 2.
Acupuncture is a quite different attitude, and we had a Chinese professor in acupuncture in our department, and he said it's not affecting many known ways, and lidocaine is directly interfering with the mechanism of neuroinflammation, so it's a complete different mechanism. Acupuncture can emphasize certain effects, but it will certainly not be the way to treat all the tremendous effects it has. That's also what he stated. So, and I think that's good to notice. And I don't think we have any more. We haven't seen any detrimental effect of lidocaine. It's also not written in literature. The only thing, we give it subcutaneously, and everybody's talking about plasma levels. We're not interested in plasma levels. Our plasma levels are very low. That's why we do put it in subcutaneously. We put it just under the skin, and there it's directly affecting the immune system. It's going to the lymph node regions, and there it has its effect in modulating the T regulatory cells and having there a better stability in the immune system. So that's about the difference. We didn't see concentrations are too low to have any detrimental effect in giving lidocaine.
I think Dr. Lodge, yeah, thank you.
My first question goes to the first speaker regarding the surgical eye knife. Is this useful if you got a program in artificial intelligence that the surgeons using the eye knife can easily make a diagnosis of the cancer during surgery? And another thing is how useful it is in artificial intelligence in microscopy for cancer cells.
Sorry, I didn't get the question very clear. So you are talking about circulating tumor cells?
No, I'm talking about eye knife. It's an intelligent knife used by surgeons. When the knife cuts through the tumor, artificial intelligence is able to tell what type of tumor the knife is cutting through. How far is that applicable currently?
Actually, I don't know.
Oh, okay, fine.
Yeah.
I'm ahead of you.
That's my short answer.
I'm ahead of you a little. Okay.
Yes.
Yes, my name is Abdul Rashid from Somaliland Medical Association. My question regards to our first presenter. Regarding screening of and showing biomarkers in cancers, it's quite difficult to exactly predict where is the origin of the tumor and what type of tumor is it. But it's still available machines or biomarkers tests, screen tests in market are quite costly, and they don't predict exactly where is the origin of the cancer. Some of them, they cost, as you mentioned, $1,000 in one test. And in the context of Kenya and many other countries in this region, due to the socioeconomic status, it's very challenging. And you mentioned only about 5 are having screening biomarkers like lung cancer, breast cancer, etc. About the 71% that you mentioned had not screening, many of them are common in our context. But currently, what you should predict practically applicable screening tests that can be cost-effective, available in the market here in Kenya?
So you're asking a very good question. Also, I think it's a comment. So in terms of the cost for the panel of 7 proteins, so it's roughly $20. I think if we do it at larger scale, if we work with the company, perhaps we can reduce the cost. So so that's for the test I presented. And your second comment is related to what going to be the near future for cancer screening, especially in this area. So the blood-based screening for multi-cancer type is going to be the next generation. It's going to be a method that you use one test to screen as many as possible. So we do see that in United States, in UK, and also in China now. So I believe in the next 3 to 5 years, those blood-based, we call MSAT, multi-cancer early detection tests will come out. So as I presented, so there are expensive versions. There are also like the cheaper versions we have. I think in the future, we'll continue to evaluate those cheap versions. In the same time, to improve the cheap versions for both cost and also for the clinical performance. So we are going to do an additional study and also going to get more samples and also to use different algorithms to improve the clinical performance. So I hope I answered your question.
Any other comment? Yes?
Yeah. Can I start from this end? Here. Sorry, my question is for Dr. Rob. Thank you for that presentation. I'm just curious whether you have any comments with regards to use of lidocaine in the pediatric population, more so in the neonatal population, because in the neonates we hardly have anything for pain management, and it's been.
Speak a bit?
Hello, can you hear me?
The mic.
Can you hear me now? Can you hear me now?
Yeah.
All right. So I'm just asking whether you have any comment with regards of use of lidocaine in the pediatric population, more so in the neonatal population, because in this group we hardly have any reliable sort of medication to use in pain management, especially in the neonatal population, and it's been proven that lidocaine is actually cardiotoxic. To a certain extent due to the changes in pharmacodynamics and pharmacokinetics. Thank you.
Well, the pharmacokinetics from lidocaine are completely different when you give it this intracutaneously or by any other route we tried. We measured the plasma levels, and they never exceed some even dangerous thing by 10% of the maximum maximum dose that the first side effects exist, will develop. So also I gave to a lot of end-stage oncology patients, and never I saw also with continuous by pump about 1 milligram per hour for about 2 years, and never saw any detrimental effect. So it's very, very safe. Also end stage with liver, end stage kidney failure. It's integrated in the working mechanism, and that's why we have to rethink what is pain and what is neuroinflammation. It's a new way of thinking about pain. And patients will benefit from this new idea, new thinking.
Yes, go ahead.
Okay, Dr. Jakait. The first question is to Dr. Mau Mau. This OncoSig, the 7-protein panel, have you subjected it to racial differences? For example, from the Chinese to the Africans? Because there are a few studies that have shown that sometimes those markers respond differently to different races. So if not, I had you mentioned you would wish to do them here and maybe do further studies also. Maybe it will be welcome to try. The second one goes to Rob. The issue of lidocaine, the mode of, you've said 1 milligram per kilogram per hour. How do you administer it? Is it using an infusion pump, or somebody has to stay there every 1 hour with a timed clock, give a subcutaneous injection? Then the last question on you is, you mentioned you would prefer to use it in conjunction together with gabapentin and amitriptyline low doses. Have you tried pregabalin instead of gabapentin? Why would you prefer gabapentin to pregabalin?
Yes, thank you for this nice remark. Your first remark is completely correct. I discussed it with Kma, and we should find an applicable way in, not only in Africa, also in Holland, to administer this dose. We have several new developments in which we administer the lidocaine in a different way. We can give it by oral spray. That works perfectly, also with my long COVID patient. This works also good in some of my patients who were not able to get it by lack of cooperation of insurance, general practitioners and so on. They only were convicted, well, let's say convicted to the spray, and they also had the same good effects. With one was pancreatic cancer and the other was advanced bowel cancer, so with all metastases all over the place. So they had the same beneficial effects, and they lived about 1 or 2 years without any pain. Yes, I use gabapentin for many, many years, and I prefer, and that's also what is in common sense in the modern literature dealing with pain. Gabapentin has benefits above pregabalin. It might be the same, but it's completely not. Pregabalin has some addiction properties, and that makes it in the long term with longer duration of use, makes it less effective. Also, you need a correct liver function to modify pregabalin into the gabapentin fraction. Gabapentin is in fact one of the most perfect drugs. It's not metabolized, it's excreted even with the lowest kidney function we have, unaffected by the body, and it does the job on the spot, and it does the job in the brain. And I use very low concentrations. We don't need much. We don't need high concentration. It's not the higher the better. The more pain, the higher the dose. No, that doesn't work anymore. And it's the combination of the drugs, the combination of low dose gabapentin with low dose amitriptyline and the atorecoxib above the old NSAIDs with the COX-1 effect, that makes this trias very powerful and very good. It's even as powerful as quite severely high-dosed opioids.
Let's have one last burning question.
So you asked the racial differences of those markers. First of all, in terms of cancer biology, so they are pretty much the same across different racial groups. There are many studies on this. So basically, we share the same cancer biology. So AFP is a good marker for liver cancer in China, but also it's a good marker for liver cancer in Africa. And secondly, so the third cohort, the second validation cohort is from Johns Hopkins University in United States. So basically, that cohort is a mix of Caucasian, Black, Asian, and Hispanic. So we have good performance in the Johns Hopkins cohort.
You can now take the last burning question, if there is any. Last burning question or comment? I think it's been exhaustively dealt with. Thank you very much. Can we give a clap to both our speakers? Thank you very much. Dr. Kitao will come for the next session. Thank you.
Good morning. Before I introduce our next speaker, I want to acknowledge the presence of our Chief Guest Representative, the Secretary Administration, Ministry of Environment, Climate Change and Forestry, Mr. John Elangata, who is representing the CS Honorable Soipantuye. Salimia wat? Okay, asante. Okay. Our next session is a very special session from a very accomplished Kma leader who will be coming to speak about quality of life and outcome measure in quality healthcare. He is an accomplished chest physician who has served in various capacities, including being a director, Communicable Diseases Ministry of Health in Kenya, National TB Program Manager, Director TB and Respiratory Disease Research Center, KEMRI. He served as a lecturer at the Department of Medicine, University of Nairobi. He served as a chest physician in the Kenyatta National Hospital, Head of Infectious Disease Hospital, Director Training, Clinical Officers Tuberculosis, Leprosy, MTC, and has had several consultancies with the development partners, including WHO, and has served as chairman of several parastatal boards in Kenya. He is indeed a past chairman of the Kenya Medical Association. He's a founder of the Kenya Association of Physicians. He's a patron, Kenya Association for the Prevention of Tuberculosis and Lung Disease. He's a past chair of the International Union Against TB, past VP, Commonwealth Medical Association. He's a current president of Pan-Africa Thoracic Society and the chairman of the HIV Clinician Societies of Kenya. He's also the overseas representative of the Royal College of Physicians in Edinburgh. Indeed, quite a very long CV here. I want to introduce Dr. J.A. Aloch. Karibu sana. His presentation.
Yes.
It has your presentation?
Yeah. They told me we had it. Always bring it. Good morning. I think when I was being introduced, I wasn't sure that was referring to me. I thought they were talking to somebody else. But it looks like it has a resemblance of my CV sometimes back. It's now more than that. Yes, I think she should update it. And it forms a legend itself. Now, if the organizers could get my slide. Now, all of us as doctors, we have got one primary aim in view over the years is that to improve the outcome of our patients. You are all here simply to improve your continued professional development. And why do you come to improve your professional development, Daktari? So that when you go back, you can improve the outcome of patients. So the primary aim of doctors all the time is to improve the outcome of the patients they care for. And over the years, this has been just a special kind of preserve for doctors to decide, I think we're doing better. It was the doctor who decided now we are improving our patients' outcome in a much better way. First of all, they were using the measure. Oh, the rain must be a blessing for this occasion. I hope you can hear me despite the outfall, because I can't hear myself. So for many years, we based the outcome of our clinical care on the morbidity reduction and mortality reduction. That is curing the diseases and reducing the number of premature deaths. That's mortality reduction. And what happens to the patients who have cured the disease or reduced the mortality? We didn't pay much attention, i.e., okay, somebody was sick but did not die, say those people with the cancer. This is particularly relevant with a cancer patient. A lot of them, you can reduce their cancer aggressiveness, but the type of life they lead, first, due to the drugs they use, and due to the other intervention used to reduce the cancer, may make their lives so miserable. We are all familiar with that. So this was one of the earliest, one of the earliest areas where we applied the quality of life as an outcome measure in all our intervention. If you don't have it, I got my presentation there. Yeah. So we now realize that it's not just curing the patient that you're after, or this that you remove shape on the other side. So this I have to turn around. You didn't have a prompter here. You're not quite digital. Okay, so no, just leave it here. Okay. So quality of life. So now we are tending to talk more about quality of life in measuring the outcome of all our medical intervention. And the quality of life is not just the doctor who decides. In fact, more important is the patient who says, okay, fine, doctor, I think the treatment you have given me has improved me. Not you measuring some laboratory report or saying, oh, the PSCP is down, so this patient is recovering from pneumonia, or CSP doing well, or Dr. Yosa doing 101 tests. And they're treating the laboratory test, not the patient. The patient is feeling terrible, but they say, oh, the reports are okay, patient is improving, oh, the X-ray is okay, they do X-ray every day. So we actually do a lot of terrible medicine. And in fact, a lot of patients survive in spite of doctors, because a lot of doctors actually do more harm than good to the patient. So we have now to look at the quality of life. Okay, now what is this? What is this? What's happening to this thing? Yeah. What is this quality of life? Now, I'll try to look at it at 3 angles. First, I'll define what it is, and it's very difficult to define. I may identify a few components of quality of life, and finally, to understand and calculate the measures of quality of life. Are you able to see my writing from the back? Yes, you can. Yeah. This is what I call good presentation, because some of the slides you can't see from back, so that's poor presentation. Okay, if you can see that well and clear. This is from an experienced man. Okay, fine. This is health definition. Okay, so don't make your slides so busy. Now, health from WHO definition is a mental, physical, and social well-being, and not merely the absence of disease. Now, in 1946, the whole idea of outcome of treatment changed when WHO said that health is not just physical well-being, but also, mental, social well-being, but also the absence, extended well-being of the patient, not just absence of disease. So when you talk about quality of health, now we talk about well-being. The WHO perception of individual perception of their position in life is a context of cultural value system. So you look at the whole patient in a cultural system and the degree of satisfaction he has in that community, a feeling of his functioning and happiness in that community. These are all. Now, there are several definitions of quality of life according to who is defining whom, and I'll give you a few examples. First, quality of life is a degree of need and satisfaction within the physical, psychological, and social activities, material and structural area. That's what done by Hodgkin in 1982. Quality of life is a subject evaluation of satisfactory character of life. So basically, it changes a lot, and it can also be just the satisfaction of an individual and a feeling. It's also quality of life is also a state of well-being according to other definition, composite of two components. One, the ability to perform every activities which reflect physical activities, psychological activity, and social well-being. Another one is the patient satisfaction. Okay, you must be satisfied, and you must also be able to perform a lot of function and control the disease and treatment-related factors. Now, it's important. Not all treatment do you good. Some of the treatment may do you harm. So the problem is that we have no clear definition because the clinical decision making, some of these definitions are different. The patient may not benefit from the treatment. There's a lot of epidemiological aspects and the morbidity of the population, so, and health economics. So all these. So let's talk about the components of quality of life. Well, from the physical component of quality of life, you have energy. And all of you are energetic, that's why you are here. Apart from a few of us who are a bit old and now are a bit not so energetic, but you guys are all active and daily living and work capacity, and you all got good psychology. You're fearing nothing, you're not depressed, you're self-esteem, proud of yourself. You've got a good memory, hopefully, some of you, and you can be able to concentrate on a lecture like this. That's part of a component of your quality of life. So if you cannot comment, now this is a bit controversial, but spiritual. You must have religious, personal interpower, but please be careful which religion you belong to. Some of them may not be so spiritual. Then you must have social relationship with the people. You must have people to like you. If nobody likes you, your quality of life is zero. Okay. If you're miserable looking and staying alone, and you must have an environment where there's no pollution, there's no noise, there's no traffic, and everything is fine. And this is kind of a quality domain of life domains, which can be divided in several qualities, including autonomy, freedom, health, physical, productivity, personal possession, and that is not so important, okay? And this is the big picture that gives you the quality of life, which includes all those social I've talked about, and activities, and health status, and health-related quality of life. So, when all of you treat, and you've already been talked about management of cancer and cancer pain, that's really treating. So why do you offer treatment to a patient? Yeah? There's good reason why you offer treatment. One, you want the patients to live longer. How many of you are over 65 years old here? Hands up. Those who are over 65 years. Okay, so most of you now, if you die, there's no problem. You're not a premature death. The only time, all those under 65, if you die, is a bit, you don't need to live very much long about, never mind about me now. Okay, then you prevent future morbidity. That's you do a lot of things, and make the patients feel better. The first two of these components are easy to measure. We have physical way of measure how long you can live and how prevented the morbidity. But the third one, is the one difficult, and that's where we come in quality of life. So several investigators have developed increasing sophisticated methods of direct measurement of some of these people, how they're feeling and how they're able to function after a certain management or treatment. But please note, as I said earlier, it is worthwhile to secure happiness of the patient, but as well as prolong his life. But there are times when life is possible, but life for what purpose? Let's say, for example, intensive care services save life in the short time, but prolong death in the long time. So a lot of people stay in the ICU, not because they're going to survive, but because you want prolonged death and make death very expensive. So a lot of technology has made death a very expensive exercise. So you have advised not to die in a very highly technological surrounding, because it's going to be very expensive. And the same thing in cancer. A lot of cancer treatment over the years. In fact, quality of life was something which is highly developed in cancer chemotherapy. And as the cancer people will say, add life to years, not years to life. And that is basically talking about quality of life over the years, which we have all to talk about. So there's something we talked about, health-related quality of life. This refers to a group of people perceived physical and mental health over time. It measures the effect of chronic illness of a patient, whether it's got diabetes, asthma, rheumatoid arthritis, how it helps you, how it interferes with the person's day-to-day activities, how it gives you long-term and short-term disability, and or what other health-related life will represent the functional effects. And the two domains, you look at them. One of the aims of treating patients must be to enable them to feel better and function better in their day-to-day activities. Okay, not just keeping them alive. So quality of life goes beyond keeping life. As they would say, that life possible, but life for what purpose? Many people are on a machine or vegetables. They're all alive, but they never be useful to anybody. Although purists say that human beings have no power to take away life. They don't give life, so they can't take it away. And that's what offensive. We have to continue being people on the machine for months, even for years in some cases, just because they can afford. But they'll never know who they are, they never know who's around them, they never talk to them. And it's a stress. And the same thing, this is what has been called the failures of our successes. We've succeeded so much in technological evolution in medicine that we are saving a lot of people that would otherwise should have died, and it let you happy. A lot of so-called special babies, they're pretty useless. They are nuisance to the mother. They make the mother sick. You can't leave them alone. You have to run around everywhere with them. Whatever they're going, they are risk to themselves and to everybody else. And yet, because of the technology, they kept alive, and they're called special babies. But in real life, they have no quality of life, and they reduce the quality of the mother because the mother cannot do normally. But it's difficult. It's up to you to decide what quality of life you want in that case. So how do we measure quality of life? Okay. It's not easy to measure quality of life directly, but you need to estimate some of the components of quality of life and its constituent domains so that you can quantify those. General health, perception, physiological well-being, and functioning are essential dimensions of quality of life. We have 100 ways of measuring some of the quality, which have been developed in recent years. In fact, a lot of scientists have developed various generic and specific tools to measure quality of life. Some of them can be quantified. In fact, now we can quantify whether your life in this world is economic. Now, economics, we say clearly that if a beggar dies on the streets, economically the country has lost nothing, probably gained something. Okay, but moralists would say the country has lost something. It should have been done. But it depends. Now health now has gone beyond just curing the disease. It's also health economics. And quality of life depends a lot on health economics. And we'll talk about quality of healthcare tomorrow. And you see, there's not the skill of the doctors and the equipment and the establishment of the institution that we use to treat a patient that matters, but also how much it costs. Also adds to the quality of life and the quality of healthcare. Now, quality of life can be quite difficult to measure. There's various methods of trying to measure it, which may not be very successful. But there is, whatever method you use must be valid, reliable, above all, accurate and adequate. So there are some of the way of measuring, but there are no standard scale of measuring healthcare related quality of life. You need to be specific in what you want to measure anytime and assemble several indicators with approximate the concept, then create a score combination. And some of this may be not reproducible. But whatever it is, there's several ways we can do it. This includes just general observation, surveys, discussion, semi-structural interviews, focus groups, video evidence, third-party reports, assessments, complication of tasks, and all these can be, and this measuring quality of life can either be administered by a trained interviewer or maybe self-administered. The former is very expensive. It involves employing a lot of people and doing the interviews, but it's more accurate. The latter may be cheaper, but maybe a little inaccurate. So you have to get a compromise between self-administered and structured administration of questionnaire by people, and get a kind of a compromise between the two. And the importance of measuring quality of life is important to assess in the whole group, the community health status, and assess how well the patients are satisfied with what you are doing them, and assess the quality of life of the people who may be handicapped, okay? So selecting assessment include generic, and a generic thing means what it is. This is a general population. You assess a wide area of domains applicable to a whole community condition of this. See the effect of disease like asthma in the community, or diabetes, or cancer in the community. On the other hand, it can be disease specific. So you focus on a particular disease on an individual. See the effect of rheumatoid arthritis, the effect of cancer pain on an individual, measure that one, or how it's affecting his sleeping, or affecting his other function, or population, patients, children, and the elderly. So you can do specific, and generic are easy to measure compared to specific. Now, disease specific, probably the basic approach to quality of life, and must be used in all cases when you want to measure. And this is now actually used by the World Bank to assess, particularly in the community, the effects of the disease in a life. Now, there's what is known as quality adjusted life years, QALYs. And this is also useful in chronic diseases, again, particularly cancer. It assesses the number of years you live with high quality of health or without disability, or prevent or mature death. This is used in economic estimation, especially cost utility analysis. And say 1 year of perfect life is equal to 1 year times 1 year utility, which is one QALY. And best life is 1, and worst life is 0, which is death. Then there's disability adjusted life years, which relates to WHO considers a measure of global burden of disease. This is an international quantitative indicator of burden of disease in a community. And it talks about disability adjusted life year. That is the years of life lost, fatal disease compared to the morbidity. That's the year lost due to disability. That's the year lost due to disease. The quality of life adjusted here, that's quality and disability, are all related and they mean the same thing. And they actually we analyze. Quality adjusted year, the other one adjusted life years. Quality measures the quality of life, and then it measures the health loss in the quality of life. And this can be correlated from 0 to death. A quality assesses year lived with high quality. Daily assesses years lost of high life. They are all comparing each other, as you can see there. And you can do those analyses. They're very good mathematics. You can use each disease or each cancer or each disability, and they come out. And there are several methods of using them. Basically, you got the visual analog VAS scale, time trade-off, standard gamble, and VAS has been used for a long time, from 0 to normal, from trade-off, particularly people in a wheelchair, comparison, evaluation of method. Visual analog is easy compared to standard gamble or time trade-off, which is less easy. Okay. The main question is some of the assessment cannot be done without the patient answer question. And this is where the so-called PRO came, patient reported outcome, as part of quality assessment. That is, the objective of much healthcare is improving how the patient feels and function, as I said earlier. And you wonder whether the patient will get reduction of pain, improving walking, he's able to walk, tie his shoes, make her breakfast. So the patient is the best judge in these cases. Before the doctors took in among themselves to be able to assess how well the treatment is doing. He's offering the best cancer treatment. I said, okay, I think this is doing very well. Cancer improvement rate or our improvement for heart pain. I don't need more than 10 minutes. I'm already done. Okay. So these are important. So PRO is measurement of patient's health status. It have examples of function, symptom, intensity, and well-being. Okay. So PRO is directly reported by the patient without interpretation of the patient's response. You don't say anything else. What the patient says, you also record. And this can be measured in absolute time, so the patient's rating of the severity of pain or report of changes from measures, onset of nausea when you administer a new drug for cancer, for example. Okay. SF36, that has been used for a long time to measure physical and mental component of a patient in the quality of life measurement. One measures physical function, role of physical bodily pain, general health, and the other, of course, mental health, the role of emotional, social function, and validity. And these are 36 questionnaires which have been formed in AIDS fashion, and a patient can fill the form, and you should be able to this is so-called short form 36 questions, and they're normally self-administered. You cannot even use phone or interview, and the 8th grade level short question which are positive or negative worded, redundant, reliability, to find out the time twist, that is time without symptoms. So the take-home message is, Gitawu, you can be happy is ending. There are problems with assessing quality of life. There are scientifically sound solutions to this problem. What is not measured cannot be improved. And what is not defined cannot be measured. And what is not improved is always degraded. And thank you, if you've been paying attention as well, and thank you, and sorry, no question. Thank you. Thank you.
Thank you very much. It's a Kma tradition that the chairman's speech is never discussed. I think Dr. J has gotten used to no questions. But in the interest of time, because we do have our guests for the opening ceremony almost here, I'll probably take any one burning question from this side and one from this side. Dr. J will be here with us during the conference, so in case you have any more questions, feel free to let us know. Any burning question from this side? Ah, good. Very nice. This side? Dr. Otara. Somebody bring a mic here in front. So we'll take that one question. Kma Sako, if you're ready, please come nearby.
Thank you so much, Dr. J. Mine is just to thank you for what you presented. Number two is the emphasis you have laid in terms of quality of life as a perception by the patient away from the clinician. I think that is well captured. However, I think there is a third party that we need to talk about when it comes to perception of quality of life, particularly the end of life, the terminally ill, and this is the next of kin, the close people there, the relatives. What is the perception in terms of the patient's quality of life? And I think this is what has affected most of the doctors and the clinicians' administration of care towards those patients who are terminally ill, because it can bring about medical legal issues. They're also affected. They push the clinician to continue doing the things that you've just said without considering the patient's personal quality of life. So how do you propose we go around the third party in quality of life?
Thank you, Dr. Tara. That's very interesting. But you see, we're talking about patients' quality of life, and I told you the most important thing we realize now is the patient's reported outcome. That's more important than what anybody else reports. So we are not depending on the report from the relative or the caregiver or the. That has been now downgraded because it used to give very false impression. Some of them was biased. Maybe the relative wants the patients to die quickly, so you can see this patient is useless. I don't think you should stop. So that's not right. Okay. So we no longer depend on the third party. We depend on the patient-related outcome. The issue of terminal care and intensive care is very complicated. That's a subject for another day, which I'm prepared to talk about.
All right. Thank you very much. We are breaking for tea in a few minutes. A few announcements before I invite Kma Sako to just say hi to you. That's our sister company, or is it our daughter company? More like a daughter company. So a few announcements for those who are looking for the e-program. We are going green in view of planetary health. So the link to the e-program is provided on your email if you'd registered. If you've not registered during tea break, or if you've not received it during tea break, please see the registration desk. They'll be able to help you to access the e-program. We have a wellness check and cancer screening offered by one of our partners here in Mombasa, Mikindani Hospital, and another partner just outside the tent near the nice vehicles that you see. And you also have Toyota Kenya here, Sfao Motors. Don't go home without a vehicle. Kma Sako is here to give you money. Wi-Fi password is available. I think the password is Paradise Small at 123. So you can start downloading the loan forms so that you get your vehicle. I'll invite Dr. Vitalis Ogola to come and say something on behalf of the Sako, 5 minutes only. I saw the CEO around. Maybe he can come so that people can get to see him.
Good morning, doctors. My name is Vitalis Ogola. I'm a dentist by profession, and I also sit in the board of the Kma Sako. I'm glad to join the doctors this year in your conference in Mombasa. As stated, I will not take too much time. Kma Sako is to preach the gospel of money. We have just been talked to by our very respected doctor as regards quality of life. I know there are many theories as regards money, but I come from the school of thought that if you have money, it lessens some problems. Doesn't mean that you have to be in business. Now, Kma Sako, I think by and large, having interacted with most of you, I've seen there are quite a number of members here who patronize the SACCO. But this SACCO marks 25 years today. It was begun 1998 by some of our respected members here. And it has grown through the journey. You could move the... It has grown through the journey that at one point there were fewer members, and in 2021 we became as part of the regulated SACCOs. And amongst the SACCOs in this nation that are non-deposit taking, those that don't operate like banks, recently SASRA, you could move to the next, ranked us as, again the next, ranked us as the third best performing SACCO. The SACCO belongs to doctors, dentists, and pharmacists. The SACCO belongs to doctors, pharmacists, and dentists, and your dependents, and your wife, children, and your employees. You could as well register your institutions. Now I know doctors have made their clinics in a corporate way. So you can also join the SACCO as a corporate body. I, as a dentist, I could register my clinic, and the dental chair that I use, I can buy it by the clinic and not me, so that we're separate. And then you could move to the next. At the moment, the SACCO offers you different loan portfolios. I always say that we need to save. And at the moment, you also need to use loans. Loans is just basically using other people's money to implement your ideas. So we have a development loan that the interest is basic. It doesn't change. It's at 12%. You could move. Oh, sorry. Yes, we have a development loan that can give you 3 times your savings. So if you save 1 million shillings, you can get 3 million for that. And we also have a flexi development loan, which we can give you at 4 times what you've saved, and at 13.5%. As you know, in Kenya lately, our interest rates have really gone high. It keeps changing. But at the SACCO, it is static. I've met doctors with good ideas. Please, we have enough money. You can get as much as 100 million, 50 million to implement your ideas as we ascertain your ability to pay to help you grow. Other than that, for the interns, now if you're an intern as you join, I know some of them were here yesterday, we can give them a loan of up to 100,000. I think most of us remember how the first few months without the salary becomes really tricky. So this is a package for them. We can also buy assets. If you want to buy some piece somewhere, some plot, some building, through the equity release, we can buy it for you. The thing that you need is that you have to raise 1/3 of the value by yourself, and the 2/3 will be catered for by the SACCO, pending your ability to pay. So if you have dreams and you can pursue property, that is not tied to your savings. Normally people come to the SACCO and say, you know, unlike banks, I have to save up to a certain amount. But if you want to buy property, if you want to buy some assets, then your ability to pay and the total amount of, and you being able to raise 1/3 of it is the benchmark and not necessarily your savings. And then, of course, we also have there's asset finance and equity release. Now, asset equity release means you already have a property and you want to borrow against it. We can give you up to 80% the value of the product. And then, of course, home loan. We have a home loan at the moment. We don't help you to build, but if you have a house that is complete, if there's a structure that is complete, the SACCO can buy it for you, and that we give at 5 times your savings. So if you have saved 5 million shillings and you have a property worth 25 million, you can come to the SACCO and buy it unless it is complete. So, and then we also have insurance that you can process through the SACCO. If you have cars, you have indemnity. I always tell doctors that I wouldn't take my indemnity anywhere, because if the SACCO coughs to any insurance that is being unfair to the doctor, then they would respond faster because you have a bigger pool. So feel free to join through the SACCO to have your insurance processed. So, and one thing that is really key in our SACCO is that at the moment, I think we're probably the only SACCO that if one dies, We have an insurance that your dependents will get twice your savings. So if you saved 10 million with us and you passed on, the SACCO would give you 20, you'll give your dependents 20 million. I think that's probably higher than what the many insurance products that are normally sold to the doctors. It's a key thing for us that I think we need to share. So as you keep saving in your life, even when the damage comes, when you pass on, it would be to your interest. That is my presentation. I don't want to take too much time. It is said that change doesn't necessarily mean progress. But deciding to save is progress. By and large, most of us find ourselves at a younger age not thinking that in a few years some things will catch up with us. I'm fairly young, I've seen very senior members, but I always challenge my fellow young people that your life gets expensive every year. The rate of return doesn't increase that fast. So if this year you're making some money, and when you're younger you get fooled that of course there's always a rainy day. Everybody imagines there's some day that some windfall is going to come my way. From the readings I've had, it's never that way. It's the incremental savings that you do, it's the little savings that you do that will ultimately build into something. If you're sitting here, young, old, and you have some money, and you have the temptation to buy things you don't need, remember you're stealing from yourself. Save that money, bring it to the SACCO, invest in your ideas, and grow with it. If you don't remember my name, please remember to join the SACCO and save. Thank you.
Thank you very much, SACCO team. You've done a lot to boost us socioeconomically. We are now coming to the end of our first sessions, and thank you very much, each and every one of you who has given time to come for this one. It's full house, and we hope that this will continue. We are now closing down. Thank you very much for all the speakers, and Dr. Loach, the last one. That was commendable indeed to bring the new concepts in quality of life. One simple housekeeping announcement. In one of the booths, they are just setting in, our host division, which is course division, has offered what we call wellness checks. This is a relaxation period. You should be in relaxation mode, but you can go and check your blood pressure. You can go and check your BMI, and they will interpret to you. Remember, this is May measurement month, so we're incorporating it. There's a bit of a questionnaire, you can fill it. We'll also do blood sugars. We also have what we call quick cancer screen. The host division is a passion for community work. So things like PSAs and a few others can be done, even malaria can be done. So if you need something urgent, some pain relief, etc., leave us a message there, so we'll assist. Normally people have a chest pain, have a headache, and etc. So the host division wants you to feel very relaxed, including PrEP, because Dr. Loach is here. So if you need PrEP, that one will be okay, just reach me. I can see many people are smiling because of PrEP. Hakuna matata lakini iko nini? PrEP iko. Karibu sana. Now it's time for tea, and please come 5 minutes to 11 so that we are starting our opening session. Thank you very much, each one of you, for coming. Enjoy your tea. Thank you. Pardon? And then, of course, we have got the booths, the people who have made this a success. Make sure you have time to go through all the booths. And let me thank our chair lady and Dr. Elizabeth. We give her a clap for being able to do the work. Karibu chai. Thank you.
Peter, is this your house?